Okay, so everyone, you're very welcome to today's webinar. I'm delighted to be joined today by Roisín O'Maolalaí. In case you haven't met me before, I'm Michelle Leach, Professor in Radiation Therapy here at Trinity College Dublin, and I'll be chairing today's webinar. So Roisín graduated from the BSc in Radiation Therapy in 2016. Feels like a lot sooner than that to me, but there you go. And since then, she had worked clinically in Cork University Hospital and in St. Luke's Radiation Oncology Network in Dublin as radiation therapist. And then Roisín started working in the clinical trials unit in St. Luke's Radiation Oncology Network as a research radiation therapist and a trial coordinator in April 2021. She's been very busy because she completed a part-time master's in applied social research methods through Trinity last year. And she's been working as the Irish Research Radiation Oncology Group, or IRROG, manager since June of this year. And setting that up and managing that whole system is what she's going to be speaking to us about today. So thanks, Roisín, for joining us. Whenever you're ready, I'll let you share your screen. And while you're doing that, I'll just say to anyone listening, if you have questions for Roisín during the presentation, if you use the Q&A function, please, not the chat, Q&A, and I'll pick them up then at the end of the presentation. So if you're ready to go, then Roisín, I'll stop talking and hand over to you, and thanks very much.
Great. Thanks so much, Michelle, and thanks so much for giving me the opportunity. You can see my slides there, can you?
Yes, perfect.
Brilliant. So as Michelle said, I'm going to be chatting about the setting up of IRROG and sort of what the need was for it and where the idea came from, and our achievements to date since the group has been set up, mostly about the number of trials that we've managed to open nationally and our accrual numbers to those trials. And then I'm going to talk about what we're focused on for the next 2 years in terms of investigator-initiated trials, our RTQA program and our website, as well as some upcoming trials. And I'm going to speak a little bit in detail about one of our investigator-initiated trials as well. So World Cancer Day 2025 happened there recently, and I just wanted to make a note about one of the quotes from Matthias Guggenberger here, the ESTRO president. So he said, "Innovation is essential to meet the challenges of modern cancer care, and future breakthroughs depend on collaboration across patient organizations, industry, and the clinical and scientific communities." So I suppose a lot of what IRROG does is look at increasing collaboration across all hospitals in Ireland with our patient groups, industry, and a lot of charity partners to try and increase the number of clinical trials available to patients receiving radiation therapy. So 50% of cancer patients receive radiotherapy during the course of their illness. 40% of cancer cures are attributed to radiotherapy, and yet only 3% of public cancer research funding is spent on radiotherapy research globally. So I think that's a really stark figure. And that's sort of another key area that IRROG being set up is really about trying to promote radiation oncology research within Ireland so that we get our fair share of funding, which will enable more radiotherapy research to happen in the country. So what is IRROG? So we're the Irish Research Radiation Oncology Group, and we consist of the 5 public radiotherapy departments in Ireland. So in Dublin, there's 3, and they're combined within the St. Luke's network. And then there's a public radiotherapy department in Cork and Galway. And we also collaborate with private radiotherapy departments in Ireland as well. We have more than 100 members, and we have an active public and patient involvement group. So that's a group of patients within IRROG who've had radiation therapy in the past, and a number of them have also participated on clinical trials. So their kind of understanding of what it's like to be on a clinical trial, what it's like to have radiation therapy is really important and guides us a lot in the type of trials that we're going to open, and the best way to open those trials in a manner that's kind of makes the trials accessible to patients, that patients are eager to participate. So their insight is really, we found, so valuable in all the work that we're kind of doing at the moment. So I'll speak a little bit about why we felt there was a need for a national group. So prior to IRROG existing, I suppose there was a clinical trial unit in each radiation therapy department in Ireland. But some of those clinical trial groups were quite small, not, I suppose, always staffed fully. And so because of that, it became quite difficult for those trial units to open all the clinical trials that could have been opened in those departments. So in the St. Luke Centre in Dublin, we'd had a clinical trials unit in existence for 20 years. It was quite well funded by a charity partner, the St. Luke's Institute of Cancer Research and the Friends of St. Luke's. And that meant that there was a lot of experience within the trials unit in St. Luke's. And also in Cork and Galway, there had been great successes in setting up clinical trials, but again, due to some staffing issues, it was difficult for those units to keep on, I suppose, enrolling patients to trial and keep on opening new trials. It's really difficult to do that if your staffing is not always there. And so we felt there was a need to set up a national group to improve sort of the equity of access to patients around Ireland to accessing clinical trials, because it wasn't right that if a patient having radiotherapy to their prostate, for example, depending on where they were in the country, they may get access to a novel treatment through a trial, and that they wouldn't get access to that same trial if they were receiving treatment in another part of the country. So equitable access to clinical trials cannot exist in a setting where clinical trials are restricted to a limited, centralised number of radiotherapy institutions. So that was really where we were in 2021. Where these trials were only open in a limited number of institutions. And the WHO here have said that the highest attainable standard of health is a fundamental right of every human being. So really what we were saying was that it was a right of all patients in Ireland to access a clinical trial, and that through IRROG we'd be able to, I suppose, provide patients with that right. So our vision is to improve cancer outcomes in Ireland by ensuring all patients receive access to high quality clinical trials, and our mission to achieve that is to enable the safe delivery of novel radiotherapy treatments nationally through the implementation, again, of high quality clinical trials. So really the main function of IRROG is that if a clinical trial in radiotherapy opens in one centre in Ireland, it should open in all centres in Ireland, and that all patients should be given a fair chance to access clinical trials, because we know already that patients who receive treatment on clinical trials do better, and that's I'll go into, I suppose, the details as to why that is during this presentation. So just a little slide about evidence-based practice. So this quote by David Sackett here is just kind of defining evidence-based practice as the conscientious, explicit and judicious use of current best evidence. And this quote by Archibald Cochrane from the Cochrane Reviews is that you should randomise until it hurts the clinicians. So really these two people here really speaking about why we should use evidence-based practice. And I suppose evidence-based practice, like we think of it as the standard now, that every decision that's made about a patient's treatment comes out of evidence base, but that was really only largely adopted as recently as the 90s, I suppose, globally. And there's a lot of, it's still developing all the time, but I suppose every decision now that's made about a patient who's receiving radiotherapy in Ireland should be based off research that's been done through a clinical trial. So we all know that the goal of radiotherapy is to maximise the radiation dose to abnormal cancer cells while minimising exposure to normal cells. And that's really the question at the crux of all the clinical trials that we run in radiotherapy, is how we can maximise the dose to make sure we have the best possible chance of cure and minimise side effects at the same time. So that's really what we're looking at in all of the IITs that we design around radiation therapy. But we're not just running radiation therapy trials solely focused on this. We run a lot of trials looking at different IMPs, immunotherapy, chemotherapy used in conjunction with radiation therapy. So there's a lot of different types of trials that we run in radiation oncology departments. But I suppose the reason that we're running them is always to add to this evidence-based practice and to improve outcomes for all patients, not just patients who are on a trial at the moment. I'll fly through this slide. I think everyone on here will be aware of radiation therapy and how it happens. So ionizing radiation is a type of high energy radiation that is able to release electrons from atoms and molecules, generating ions which can break covalent bonds. So I won't go into this in detail, but I suppose a lot of the trials that we run, and I'll speak about one specifically in a few slides, is looking at I suppose, focusing radiation, increasing the precision and safely increasing the dose of radiation, while also minimizing the side effects of radiation. So I'll speak a little bit about our achievements to date in IRROG. So year one in 2022, setting up the national group and how we did it. So we had to hire a number of new staff. So we had the IRROG manager, physicist, research assistant, and a data manager as well to be hired. We had to establish the governance advisory board, the executive and operations meetings, which are regular meetings that are held to ensure that IRROG is being run in accordance with the Health Research Board grant. And there was new relationships. I spoke already about how IRROG is really a very collaborative group. So we were working really closely with the HRB, who are our main funders, and then Cancer Trials Ireland as well, who sponsor a lot of, or the majority of the studies that we run in radiation therapy departments in Ireland. We held the IRROG study day as well, which was for all IRROG staff and for us to learn from each other about how we run trials in each of the centres, and I suppose looking at different ways that we could improve how the trials are run, and to make sure again that there's I suppose equity of access around Ireland in each of those clinical trials. And then we also formed the PPI group, which I've also spoken about already, and we had training for those PPI group members. There's a little photo here of our induction pack. I have a call this afternoon actually with a new patient who's interested in participating in the PPI group. So all the time we're kind of looking at or trying to reach out to patients to have increased involvement in the PPI group in IRROG, but this was just 2022. So 2023 then, our second year of being formed as a group, I suppose. So we had our inaugural conference in January 23, and we're going to hopefully be having another conference later on this year in October. But that conference was really, really helpful, and we had really good attendance nationally, and we had some excellent international speakers as well. And again, it's all about, I suppose, raising the profile of radiation oncology research in Ireland, and just those conference days can be really helpful, getting everyone kind of talking and excited about trials, and just using that as kind of a jumping off point as well, really, for a clinical trial, to try and get more trials open, which we did then achieve in 2024. I'll go on to talk about that. So we expanded the number of trials open in Cork and Galway. And so there was a head and neck trial, which opened the PRESERVE trial, which was looking at preserving nodes and patient speech for head and neck patients. And that's a Canadian trial, and it was the first head and neck trial to open in all radiation oncology departments in Ireland. And Ireland was also the top accruer to that trial. So it was really helpful to get the trial open all across the country. And I suppose when you have a trial open in more clinical trials units as well, we can each learn from each other about different ways that are helpful when we're explaining the trial to patients, different methods we've used to improve accrual. And so that was a really nice example of IRROG being around and kind of adding to that trial opening in each of the centres. Another achievement we had was we opened the DAZZLE HiCap trial in the St. James's clinical trials unit, the St. Luke's unit at St. James's. We had some of these strategy meetings, which we started to have, where basically these were meetings where we have all our consultants, radiation therapists, nurses, anyone who's involved in a treatment of physicists as well, anyone involved in the treatment of a specific patient group. So we had a breast and a prostate big thinking in 2023. And basically what that meeting entails is it's just all of us coming together and saying, these are all our specialists in breast or prostate cancer, and what are the trials that are out there that we're not participating in, maybe internationally trials people are aware of and interested in opening, and also what are some investigator initiated ideas, what are issues that patients are coming up against every day that the clinicians are seeing in clinic and they'd like to open a trial to address that, or questions of like different queries about the best method of treating these kind of cancers. We also opened 2 new investigator-initiated trials, Spine Sabre and IMRT Pancreas. So really nice to open a pancreatic IIT for the patient cohort who have quite poor clinical outcomes. Sorry. I just went back there. And we also had a PPI involved in the design of a new IIT, the Open trial, which I'll speak about a little bit later as well. So then 2024 was kind of, we'd been laying all the groundwork for the first 2 years, and this was really the year where we saw kind of, I suppose, the fruits from our labour, in that we had a massive increase in accruals to clinical trials, and we opened a large number of clinical trials as well. So we opened 12 clinical trials, and I'll speak a little bit about our accruals, I think, in the next slide here. So this slide's really nice. It shows very clearly, I suppose, from 2021, 2022, 2023, quite stable there, the number of patients being accrual, and then this massive jump. And a lot of this was to do with one particular trial I mentioned before, the Open trial. So that's it's an interventional trial, and it's looking at the type of mask we use to immobilize patients having radiation therapy for head and neck cancer. And we had PPI involvement in the development of that trial protocol and in the development of the patient information leaflet. And I think the PPI involvement is really one of the key factors that led to this massive uptake for the trial. So the patient made some points that we hadn't considered. Things around, were we speaking enough to the safety of the new type of open face mask that was being trialed? Were we speaking enough about the reason that we were able to use this open face mask is because we had SGRT, surface guided radiotherapy available on the units, and the patient made the point that that wasn't clear in the patient information leaflet, the initial design we had. So he was like, I wouldn't go for that trial because you haven't told me why you can use this open face mask as opposed to the standard closed face mask, and you haven't told me why that might be beneficial. All of these points that, I suppose, coming at it from a radiation therapist or maybe a clinician, we kind of felt these things were obvious in the way that we had worded the pill, and it really was a learning experience for me on just how crucial PPI involvement is, and I would really say that one patient review had a huge amount to do with this massive increase in accrual that we experienced then in 2024. That trial is going to be closing in the next month, so that's going to be a challenge for 2025. What we don't want to see is a dip down in accruals, but I suppose another learning experience from the Open trial is that we need to open trials which are more inclusive, that a lot of patients can enroll on, because it gives more patients the opportunity to be a part of a clinical trial. And so many of the trials we open now, really, really specific trials just focused on like a very specific maybe stage of cancer in a specific patient group, and patients have to meet very stringent inclusion criteria to be able to participate on the trial. So we're opening trials now where we're saying we might accrue 5 patients to in the year, or even less. And so we also, and while those trials are important, we also need to open trials where there's a really broad number of patients who can participate in those trials. And a lot of that can be database kind of registry studies as well. Really important to open that kind of research projects across Ireland, just so that we can continue to bump up this number and get to the 6% of patients on clinical trials, which is recommended by the NCCP. So this is just a breakdown of that accrual across all of our sites. And you can see here the Open trial really bumping up those numbers. But even without that, we were still keeping just about, we were still increasing here without the Open trial numbers on the number of patients on interventional clinical trials. But it'll be the challenge this year to keep that number at least above 200 would be really nice. And the other thing that we achieved in 2024 and that we're hoping to further achieve in 2025 is the number of radiotherapy investigator initiated trials that we opened. So across disease sites, this in 2021 we had the SOURCE trial open, and I'm going to speak about the SOURCE trial I think in the next slide. In 2024, we'd opened SOURCE, IMRT Pancreas, which I mentioned, the Spine Sabre trial, the Open trial, and also in Cork, there was a health-related quality of life trial open for patients receiving palliative RT, and that was a sort of a observational data collection trial on patients' health-related quality of life using a mobile phone app. But But this is kind of the key difference, I think, between working in a radiation oncology clinical trials unit compared to working in a medical oncology clinical trials unit, in that a lot of the trials that we run are IITs. I think I have a definition here. So a study with scientific and medical merit developed and sponsored by an independent investigator or academic sponsor. And that's the key there, is that the investigators are radiation oncologists who are working clinically and who have come up with an idea, an important question that hasn't been answered, or else an academic sponsor could be university often. A university sponsor. So basically what we're saying here is that there's no one going to, for example, in medical oncology, a lot of the clinical trials are pharma sponsored. And so there's a lot of funding there from the pharma companies to run. And there's, I suppose, a financial interest in running those studies, which isn't the case with these investigator-initiated trials. So they really are questions just being asked because it's felt that there's a scientific and medical merit to answering those questions. So I thought I'd just speak a little bit about the Source Lung trial, just to give a little bit of a flavour of the type of IITs that we open. And this is the longest running IIT that's currently open in any of our IRROG centres. So I should have on the slide that Professor John Armstrong is the PI of the study. And so he was the investigator who came up with, I suppose, the question, and it was developed closely with physicist colleagues as well in St. Luke's Network. Serena O'Keefe and Ronan McDermott was the fellow at the time who contributed as well to writing the protocol. So Source Lung is looking at stereotactic ablative radiation therapy, or also known as SABR, to ultracentral non-small cell lung cancer. And that's actually been increased now to not just be, it's looking at ultracentral lung cancer and also oligometastatic disease, which is located ultracentrally in the lung. And it's basically looking at the safety of delivering SABR to these patients. So it's phase 2, non-randomized, multi-center. So basically non-randomized, there's only one arm. If patients are participating on the study, they are all receiving the intervention. It's multi-center, just means it's open in more than one hospital, and it's looking at image-guided SABR for high-risk centrally located lung tumours. And the primary objective is to determine the safety of the SABR, which is 8 by 7.5 gray treatment regimen. And your endpoint will always measure your objective. So your objective is what you're trying to determine, and your endpoint is how you will determine it. So what we're counting, an endpoint always, you have to be able to count or to measure. So we're determining whether this is safe on the basis of the rate of grade 3 or greater, so grade 3, 4 or 5 treatment-related adverse events. So what that means is an adverse event which is related to the patient's SABR, and it has to be determined to be possibly, probably, or definitely related to the SABR treatment. So for an example, any grade 3 or above event, usually a patient has been hospitalized to deal with it. So that's a good way of telling whether something's a grade 3. Did the patient have to go into hospital? So say, for example, if a patient were to develop, I think in the slide here, I have what the 4 toxicities we've encountered to date. So this patient number 5, developed pneumonitis 8 weeks after treatment. And I suppose if a patient had pneumonitis that was a grade 1 or grade 2, it might be visible on a scan, but they might not be having any symptoms if it was a grade 1. If it was grade 2, they might have had maybe some antibiotics from their GP to relieve kind of any breathing symptoms they had from the pneumonitis. But then this was a grade 3, so it meant the patient had to go into hospital for the pneumonitis to be treated. So that was one of 4 which we've experienced to date of these grade 3 treatment-related adverse events or toxicities. So just to speak a little bit more about the Source trial design, so it's looking at ultracentral lesions. So more central than central is what we have here. So basically there's a few different definitions of what an ultracentral lesion is, but it basically means it's very close to the airway or to the heart. And it's in the Source trial, it's not defined. Often this is defined as, abutting the proximal bronchial tree, or overlapping with the esophagus, trachea, or pulmonary vein or artery. On the source trial, we didn't define it just purely based on its location. It's defined through planning. So it's at the point of planning, because a patient could have a tumour located very close to the heart or to the proximal bronchial tree, and yet we could still, sometimes depending on where it is and what size it is, we can still achieve our standard planning DVCs and our full dose coverage, and that patient then wouldn't be considered eligible for the source trial. On the source trial, if the constraints, our standard DVC, our standard dose volume constraints aren't met for these types of patients, then we reduce the PTV dose in a certain portion of the PTV, but it can't be reduced to the equivalent of 60 and 30 Gray, or 60 Gray and 30 fractions for these lung patients, and that's called dose painting. And then those patients who require this dose painting are considered eligible for the source trial. So it's a really interesting trial. It's a really novel design, a really novel way of deciding who is an ultracentral patient and who isn't, as opposed to just a blanket if it's within 1 centimetre of the proximal bronchial tree or whatever. So this is an example of a patient who was treated on the source trial. And you can see here, I'll just zoom in a little bit. This is the dose around, so your 45 Gray there is in blue. But you can see how this dose just curves in here around the airway. And that there is the 3 mil PRV that was put around the airway. So that's a classic kind of source plan where they've literally dose painted just off the airway there. And that is the definition of ultracentral on source trial. So the organ at risk constraints must be respected. The minimum dose of 77% to 95% of PTV will be allowed, and that's your equivalent of your 60 and 30. So if this patient, or 55 and 20 either, if this patient didn't want to participate on the source trial, then they would be replanned to receive external beam radiotherapy. But what we can guarantee is that the dose reduction that they're receiving to this little section of their PTV is not less than what they would receive if they had external beam radiotherapy. So sorry if that's quite a detailed explanation, but I just think it's a really nice trial. And currently we've had 44 patients accrued, so it's actually the largest number of patients who've been accrued to an ultracentral lung saber trial globally, we think, based on our current literature reviews. So that's really exciting. There's going to be about 20 more patients accrued, and then we'll have completed accrual. And we're also currently in the process of opening this trial in Belfast, which will be really nice because it'll mean we'll have a pan-island IIT open for the second time, and it'll be the first time since IRROG was founded. So I'll just go on and speak a little bit about our focus for 2025 and 2026. So more IITs to get them open nationally is a really big focus for us, and to develop infrastructure to support new investigators in developing IITs. So I suppose, again, the tradition or the history would have been a lot of IITs being opened just in the St. Luke's network and then not being opened nationally, because there's a lot of infrastructure required to safely open an IIT outside of the centre it was designed for, in that there's a lot of RTQA which has to be completed to show that, I suppose, the trial can safely be opened in another centre. And there's a lot of oversight required as well. PPI involvement is obviously crucial. And so these are all, and then having more of these disease-specific think-ins to try and promote IITs for all our disease areas. So that's kind of a massive focus for us. And I suppose it's kind of naturally happened since the creation of IRROG. It's kind of almost, we had a number of work packages that we were working towards, and IITs and the development of IITs was sort of one of four, but we've kind of discovered, as IRROG has been maturing as a group, that really this is a key area within radiation oncology, and it's what makes us different really as a national trials unit, is the number of IITs that we're developing all the time. So that's a real strength for us, and it'll be a strength for us as well looking to the future and to the next grant call and hoping to get more funding from the HRB for another 5 years for the group. So that's why this is a kind of key area of focus for us for the next 2 years. And then also just raising the profile of IRROG. So we have a website in development which will launch this year. We're attending the ESTRO conference, and we have a number of posters sort of describing in a poster what this talk is described about how we've founded IRROG and what our achievements have been, and also posters around the RTQA program that we're developing. And then I suppose another key area that we want to focus on is further increasing our amount of PPI involvement, because I've already spoken about how much that strengthens a lot of the research that we do. So we just want to continue with that. I'm just going to talk about two more upcoming studies, and then we'll have time for some questions. So just to give a flavour, I suppose I've spoken about an IIT, and this is a flavour now of an international clinical trial that we're hoping to participate in this year. And again, it's due to open in all of our IRROG sites, not just one. So it's the Simplify Sabre Comet trial, and the primary objective of which is to determine if single fraction Sabre is not inferior to multiple fraction Sabre with respect to healthcare professional reported grade 3 to 5 adverse events related to treatment. So again, this grade 3 to 5 adverse events related to treatment, similar to in source, that's how they're going to assess the safety or the non-inferiority of single fraction versus multiple fraction. So I suppose straight away we all know what the benefits are of having single fraction. Whenever we offer patients hypofractionation, whenever we give them the chance to attend for less treatment visits, it's my experience they always jump at it. And from a resource perspective as well, there's massive benefits in single fraction so both for hospitals and for patients there's benefits. But what we want to show with this trial is that in terms of adverse events, there's parity. That patients aren't going to be having a worse adverse event or worse outcomes as a result of receiving single fraction Sabre. This is the schema just describing the study. I won't go into the details of it here, but just to say in Canada, there's a second randomization. So this is a really interesting study design. So I suppose if anyone here on the call was ever thinking of designing a study, I just always say that there's so much more work that goes into opening a study than you realize, and just get as much out of it as you can. So when they were designing this study, they actually are answering two questions within the one study design. So the first being this very important question about single fraction Sabre with respect to adverse events, that it's non-inferior. The second randomization is looking at quality of life reporting and PRO, patient reported outcomes, symptom screening. So they're basically randomizing patients to either report quality of life alone or to use a kind of a symptom screening tool. I think it'll be like another mobile app on your phone, where if you have an outcome, an adverse event, a toxicity, you can just you can add it into your app and this will automatically be flagged to the trial team. It's only opening in Canada, unfortunately. It would have been a really nice trial to open here, but I'm sure that's to do with the resource involved in opening this kind of study. But there's a lot more. We're seeing a lot of studies coming through now focusing on patient-reported outcomes, because patients are obviously the best people to say how they're feeling, what toxicities they're experiencing. So this would be, there's been a lot of studies about this, about patient reported outcomes being used as a tool to decide when the best time is for a patient follow-up to be scheduled. So as opposed to just having your standard 3 months, 6 months, 9 months, you'll see the patient as soon as they have a toxicity, which they will report through an app on their phone. So it's a really interesting second randomization that they're doing on the Simplify Sabre Comet, and hopefully something that we can bring into some trials in Ireland in the coming years. But it's all about getting that infrastructure set up first, finding an appropriate app and technology. So just to give a bit of background on Simplify Sabre Comet, there was a phase 2 study showing benefit to overall survival through Sabre to all sites of oligometastatic disease, and that was the Sabre Comet trial. So that was kind of the precursor to the Simplify trial. So overall survival for patients receiving standard of care for their oligometastatic disease was 28 months, and this was 41 months in arm 2. So quite a significant increase in overall survival time for patients who received SABR to all sites of disease. And progression-free survival was also doubled, and that was a significant finding as well. So there's a really strong evidence base developing around SABR to all sites of oligometastatic disease, which makes it even more timely really to look at the best way of delivering that treatment now. We've shown that the treatment is beneficial, but we need to look at optimizing how we deliver it. And then just very briefly, I'll touch on the Fast Forward Boost trial. So a lot of people on the call will be aware of the Fast Forward trial, which showed that 26 Gray in 5 fractions can be safely delivered as opposed to 40 in 15 for the majority of breast cancer patients. Fast Forward Boost is looking at those patients who also are indicated to benefit from a boost following their surgery. So standard radiation therapy plus boost. And the trial is looking at delivering that also as a simultaneous integrated boost, so within 5 fractions. So at the moment, we're only offering SIB within the 15 fraction sort of regimen. So patients get 48 fractions in 15. And those same patients will be offered to have their entire treatment within 5 fractions. There's 2 different test arms. One is looking at 26 in 5 plus 31 in 5 integrated boost, and one is 26 in 5 plus 30 in 5 integrated boost. The main point there that patients can come for receive their entire adjuvant radiotherapy to their breast in 5 treatment visits as opposed to 15. So a trial that I anticipate will accrue very quickly in Ireland. We're really excited to be opening that study as well. So obviously there's savings on unit capacity, which is really important question in Ireland and globally, because there's such a shortage of radiation therapists and the number of patients requiring treatment is increasing all the time. So any kind of trial that's looking at this kind of question should be well received in theory by the departments as well. I just have a very quick video that I might try and play now. I suppose I've spoken a lot about the benefits of clinical trials, and a lot of those studies I've described are really, technical questions and looking at dose and that kind of thing. So I'm just going to stop sharing for a minute, and then I might just reshare if I can, just to show you. This is a patient that we treated, Tom, and he's a member of our PPI group, and he came in and he did a video recording for us. I don't know if it'll play now. I might just give me 2 seconds, because I think it'd be worth if I can reshare it.
Yeah, take your time.
Now.
No problem. We can wait.
Thank you. If it'll work, it'd be nice if it does. I had it open, but it asked to reopen it. Okay, I'll try and reshare this here.
Great, thank you. Yeah, perfect. So we can hear him now. That's the only thing.
Is the volume not working?
The volume's not coming through, no.
Okay. I'll surmise what he said. I think it's on the slide I have here. Sorry, now I'll stop sharing for a minute.
Okay.
So these were his main points anyway. He said it was brilliant, that it feels like you're being monitored closely, that you get a lot of reassurance. And he said it twice, you're not on your own. It feels like a security. Everything is arranged in terms of scans and bloods, and you're not on your own, and you have a full team behind you. So I thought that was really nice. Sometimes we can lose sight, or we can get very technical about the benefits of clinical trials, but from a patient side being on the trial, another patient at a talk with Cancer Trials Ireland described it as having his hand held on his first day of school. So it's really just having that point of contact that patients have when they're on a trial, and that's a massive benefit that they notice. Like he was on a dose escalation trial for prostate cancer, but that's not what he's going to talk about when he spoke about how it felt to be on the trial. It was all for him about the extra monitoring and the reassurance. So I thought that was a nice point to make. So that's the end of the presentation. I'll stop sharing there.
Brilliant. Thanks so much, Roisin. That was
no worries.
Amazing to hear everything that's happening. I mean, there's just so much, to be honest, since 2022. It's quite remarkable, really, within three years, isn't it? You know, I have a whole pile of questions as usual, but I see that we have one in the chat from Laura, so I'm going to ask Laura a question first. And she says, it's wonderful to see that a key area of focus is investigator-initiated trials, and we're very fortunate in Ireland that we have had a strong history of radiation therapist-initiated trials. So on that point, are there any radiation therapist-initiated trials open at the moment, or are they in development? Great question.
Yeah, great question. Yeah, for sure. It's definitely an area you want to, I suppose, do more with to develop more of those, and to develop like an infrastructure where RTs get the time as well to work on IITs. The open trial actually, Sam, what's Sam's second name? Sam Ryan was one of the fellows. She's the radiotherapy fellow at the moment in St. Luke's, and she was one of the key instigators of that trial. And that's about immobilization. Like, there's so many questions around that Ortiz have all the experience on, but we would like to see more, and Ortiz are often involved in developing certain aspects of the IITs around planning and IGRT. But to have, I suppose, unfortunately, at the moment, Cancer Trials Ireland's policy is that the PI of these studies, if they're interventional studies, needs to be a radiation oncologist. And so if it's going to be an interventional trial that's sponsored by Cancer Trials Ireland, but we've been back and forth in talks with them about that to try and have that sort of expanded. And I feel that with advanced practice coming in, that would be a really key area. If there was an advanced practice RT working in clinical trials, that they would have PI responsibility and oversight of those studies. And radiation therapists for sure, but also we want to see more from all across kind of the allied health, dietetic led interventions, all of the physio as well. There's kind of a lot of space for that, and I think like the first step has been to get more consultants, different consultants, opening IITs, because even there's a strong history in Ireland, but it's probably about 3 people who've been repeatedly the ones developing these. And I suppose that can happen where certain people, that's their role, and then they keep on doing that, but we're trying to spread it out so to make it more accessible, and reaching out to the RTs as well is part of that.
Yeah. I think you're right, because when we have the advanced practitioners, they have, their role is different, their scope of practice is different, isn't it?
That's it, yeah.
So that, I mean, if they're going to be signing off prescriptions and the like, I'm sure then they'll probably be seen in a different vein by Cancer Trials Ireland, but I'm sure it's an insurance piece, of course.
It is, it's safety, yeah.
I was wondering, what would you say is the greatest kind of obstacle you've come up against in starting a trial to date?
Data protection, I'd say. It's a lot of that. It's a lot of the red tape around the trials. Like, there's so much enthusiasm from everyone, but I suppose maybe from the clinical side, it's time for people to get protected time to work on opening the trials. And then in terms of like what I was saying, what IRROG does is try and, you open in one site, you open in all sites. You would think that Ireland is one small country, that if one site has ethical approval or data protection or insurance, that it should be standard, that's the same. But no, you have to go through and reapply, and those delays can kill a trial. You're waiting 12 months for maybe to get full approval from maybe from a data protection officer in each of the sites. And by the time the trial is open, the question is no longer relevant. So that like the timing issue for me is kind of critical. But there's been a huge amount of work done on it, and there is being a huge amount of work done on it to try and resolve those issues. There's a massive push and kind of pressure up to a government level to try and alleviate those kind of delays. But that's really where it's certainly not lack of enthusiasm for patients or from healthcare workers. It's definitely that red tape is what causes delays.
Yeah, I think we've seen it across, we hear it from colleagues in other specialties as well. I mean, it's that
it's universal
interpretation of GDPR, isn't it? Is really but look,
really
if maybe in Europe they're starting to loosen the reins a little bit on it, I think. So hopefully that'll feed through. On a much more positive question than that one, it was great to hear about your PPI group. And and we find that here as well with our PPI group, that patients will show you things that sometimes are so obvious you can't believe you missed it.
Absolutely, yeah.
But so for all your studies, are the PPI group involved at this stage?
Involved, yeah. And I suppose what we want to get to is at the moment, if we have, there's a lot of ideas now, protocols in development, and the idea was already there really, and so you're involving PPI a bit later. But what we'd crucially like to do is have a patient be at the table at the very early stage, kind of back of an envelope design of a trial, because it really should be the questions coming from them is where you see real strength in trials that are designed. But there has to be a PPI component to each of the IITs that we design. And so what I do is I just go to the group. We have a group of about kind of 12 to 15 patients, and it's increasing all the time. And I'll just send out an email describing what the trial is, what the work kind of, will it be a couple of hours? Would it be how many meetings over the year? And then people come back and volunteer. And it's usually, if it's a prostate question, then patients who've had prostate cancer will come back and be the ones who are interested in participating. And it's really, really helpful every time. It's things like, how many hospital visits will there be parking in the hospitals that you're sending me to? Like those kind of practical questions that you don't think of when you're saying that you'd like to collect data 3 times a week or something. You know what I mean? There's the ideal of what you want to do, and then there's what will actually be feasible and meeting in the middle.
Oh, they're such important practical questions, particularly if people are, it's fine in the centre where people aren't paying for parking, but like if you can't A, get parking, and B, have to pay for it. I mean, it's a big outlay for people, isn't it? So it's
absolutely, yeah.
Do you think you see the time where a patient will be like a full member of a research team on a trial?
I would love to see that. Yeah, I think we definitely will see that in the next few years. And I think like one area that we need to be conscious of when we're involving people in PPI at the moment, it's fully voluntary, our PPI group. And so that's people, again, just giving up their time to participate. And I think we need to, even at this point, be looking at, we submitted there a grant application to the HRB for our conference, and part of within the grant, they wanted us to specify how PPI contribution would be reimbursed. And I think that's really important. So I don't think there's anyone else you'd ask to volunteer time, to work on a study. But I definitely could see that in the future of IRROG having a full-time PPI member, I suppose, working on the trials and coordinating as well, being the person to reach out to patients. If it's a previous patient, it's just going to, I think it's really helpful.
Yeah, it is, I think. So let me see. My last question is a little bit controversial, of course. I like to do that.
Oh yeah,
I was laughing at. I was smiling when you were talking about, obviously the pharma-based trials and all the funding that comes with them. I mean, what do you think, or what's your opinion on the role of radiotherapy vendors? Yeah, not just vendors of equipment, because of course we have so many different industries involved in radiotherapy now. If you go to Estro, you go to Astro, and you go to the exhibition. I mean, the place is huge, and there's hundreds of different people there. But yet, I would say those industry in radiotherapy has been very reticent. Get behind research in the same way as pharma is, which kind of causes a lot of problems, because people have a lot of really great ideas, but they can't necessarily, don't have the money to do it, So I don't know. I mean, what do you think about that? Do you think because I feel in radiotherapy, a lot of radiotherapy researchers feel like that will compromise their study, or it would be unethical to have X vendor sponsoring, paying for their trial. But actually,
Mm.
pharma do it the whole time and don't
Pharma do it the whole time, yeah.
So
Yeah, I think once you have good oversight of that and you're sure that it's not compromising, and you're not only like we've approached vendors before, like not just as you say Varian, but if we're doing a study, we're designing a study at the minute, looking at Sabre to prostate, and there's going to be a requirement on the trial that every patient would have a rectal spacer. So we're reaching out to the companies who develop the rectal spacers to see if they'd be interested, and they do have like a certain amount of money that they give towards research, and it's a case of you submit the protocol, and it's beneficial to get, they'll do a complete peer review of it then as well. They want to make sure what they're sponsoring is, a valid question or whatever. But it's just, there's a lot of hoops to jump through, and there just isn't enough. I don't think there's enough interest, and I don't know if it's that like they feel like it's not necessary to, maybe there's not the same level of oversight. Like pharma companies, they can't, an IMP won't be, whatever, released unless there's enough phase 3 evidence behind the use of it. So maybe there needs to be the pressure from our side as well, that we're it should be a requirement. If there's new development happening in St. Luke's, like in the Bowman Centre, there'll be all these new Linac spot. Like, we should be going into that saying like we're a research institute, and that we would want support within that, because we give a huge amount of money to these vendors, and we don't see it back in terms of research. But I think it can be done in a way that's ethical, and I think we kind of need to, because when you see the amount of funding that the other I suppose disciplines are receiving, ideally it would all be just publicly funded research, but that's just not going to be, it's not the case at the moment. And it's so difficult to go from grant to grant, in terms of stability for staff and everything.
Well, it's just, I suppose, in my mind, I'm thinking about something that we've been discussing within the university a lot, which of course is that Europe now is going to have to put a lot of funding into defence, and money will not be there for research. We have to start thinking a little bit outside the box about how are we going to fund these studies. So and for I think it's always been a criticism of radiation oncology that we bring things in, particularly technical advancements, without actually having any trials. And as as you say, you'd never bring in a new drug without that. So
without that,
I wonder, do we need to start thinking about that? So anyway, to end on a philosophical question. Anyway, look, I want to say thanks very much, Roisín. That was terrific.
Thanks so much.
To your upcoming conference. So we'll have to
make
the diary for anyone who's from Ireland for October. I think you said it was, wasn't it? Yes.
Yeah, we don't have, I think, let me just double check. We don't have an exact date.
That's okay.
No.
Keep
keep tuned. I think the 17th, but we'll be back with it. We'll be, for sure, you'll see it everywhere.
So people can
and it'll be the more the merrier.
In their diaries for the moment.
Yeah, please.
And you can firm that up closer to the time. But thanks very much.
I certainly will.
Thanks everyone for joining, and hope you all have a lovely afternoon. Bye bye.
Thank you. Thanks everyone.